So, hi everyone, thanks for joining. So, we'll wait for another 3 to 4 minutes for more people to join. So, hello everyone. So, welcome back to my channel, Learn with Dr. Akshatha. So, I am thrilled to join you guys again after a bit of hiatus. So, for those of you who are new here, um, uh, welcome to my channel. So, and for those who already know me, so they would have noticed I've lost short hiatus. So, basically, I had my exams. So, and it's for a good reason. I am a board certified IDM ID current now. So that's enough about me. Let's get started with what brings us together today. So today I'm introducing a new series that is the Crosstalks with ID. The first of us is the Rheuma ID series. So today is the very first session, the fever and polyarthritis. So I'm very excited to kickstart this session with all of you. So one may wonder why am I doing this series of crosstalks? So during my practice, I have encountered many of the situation where there are various cases which requires these cross talks or collaboration between different departments. So one of the main thing is your rheumat and ID. So we have various cases of fever of unknown origin, fever with polyarthritis, etc., where we have noticed that there is a hiatus, there is a gap in understanding of the pathogenesis or the management. So the series is to bridge this gap in knowledge so that we can have a more collaborative approach and so as to simplify the various difficult to treat or difficult diagnosis, and to ensure effective management. So without any further ado, let's begin the new series, Rheuma Crosstalks. And the first talk is on fever and polyarthritis. So these are the basic ground rules. So I request all of you to be at mute, and I will be happy to take queries in the end. Post any queries in the chat section, and there is going to be a polling option. So initially there was a VVox platform, but due to certain unforeseeable situation, we are not having VVox, but we are using the Zoom poll. So whenever the Zoom polling option pops up, please do respond. And this recording will be available on the YouTube channel for your further, if at all you want to refer further. And we have tried to make this slide set foolproof, but as a human, in case of any errors, please do excuse. And again, thank you all for joining. I hope this webinar will be helpful to all. So just an overview of the fever with polyarthritis. We'll jump into the case. So we have a 25-year-old female homemaker with no comorbidities coming to us with history of fever, which was intermittent, low grade, and it would subside on the medication from the past 5 months. And this was associated with joint pain with swelling. So initially it started with the knee, then to the in the right knee, then both the knees, then wrist and the elbows. And this was also around for 5 months. Along with this, she has history of loss of appetite, loss of weight, and of around 5 kg in the past 5 months. So, but there is no history of cough, pain, abdomen, altered bowel habits, oral ulcers, photosensitivity, rash, or TB. There's no history of exposure to TB as well. On examination, she is moderately built, nourished, and vitally stable, conscious, and oriented. She has pallid bilateral cervical lymph nodes are present, which are multiple and but subcentimetric. The systemic examination was non-revealing, and on local examination, there is tender joints. All the 6 joints which were affected, that is your bilateral knee, wrist, as well as the elbow joints, are tender. There is swelling which is present in bilateral knee and the wrist, and there is warmth present and with movement restriction, both active and passive, but there is no deformities. This is her initial investigations. So if you can see, the patient is anemic. There is slightly raised leukocytosis, which is predominantly neutrophilic. There is a protein AG reversal, ESR, CRP inflammatory markers are slightly elevated. Viral markers are negative. Your brucella was done outside and it was negative. And rheumatoid factor is negative. ANA was given as positive, 1:200. CECT abdomen, thoracic abdomen was done, which showed hepatosplenomegaly and confirming the multiple subcentimetric lymph nodes in the cervical, axillary, and the retroperitoneal region. So now I request all of you to use a poll option. So what do you think this patient is suffering from? Is it so we will just start the polling now. What do you think? Is it infective or is it non-infective? So we are talking about the collaboration between rheumatoid and ID. So the major dilemma we have, is it infective or non-infective? Okay, only 2 of you are responding. Okay, so let's see. I hope all of you can respond it. Okay, and if you move to the next one again, yes. I have put 2 questions. So this is the first question. The next question is if you're considering the differentials, what differentials would you put on the topmost? So actually there was an option for multiple choice, but unfortunately in Zoom it was not available. So you give me the option for the topmost differential you would like to consider. Okay, I think, okay, we'll wait for another 2 seconds. Okay, majority of you have responded. Let's end the poll here. So, okay, the same dilemma prevails. 50% infective and 50% non-infective. Yes, and okay, and then coming to the differentials, so divided between RA, TB, brucella, viral. Okay. So I hope by the end of this webinar, you will be able to better answer this. So the various differential for fever with polyarthritis is this big list, which is given in most of the textbooks, including your Harrison. So there is crazy confusion. So what should we think about and where should we apply the various criteria we have and how should we diagnose these patients? So to answer all that, we have with us Dr. Abhishek GP. He is a DM rheumatologist with from in SGPGI and is currently working as assistant professor in KGMU Lucknow. He has received Physician Research Foundation grant for his MD dissertation and won various prizes in the quizzes, state level and national level and zonal quiz. And he has multiple publications in national and international journal. And to add, he's my husband. So without any further ado, let's start with the session on fever and polyarthritis. Dr. Abhishek, I welcome you.
Thank you, Dr. Akshatha, for the kind introduction. So we'll jump into the case-based discussion directly. Okay, so we'll start with the great lines by Sir William Osler about arthritis. He says that there is no disease more painful than acute polyarthritis. The inability to change the posture without agonizing pain, the drenching sweats, prostration, and utter helplessness combined with the distress of febrile affiliations. So, this is the distress and misery associated with acute polyarthritis, as said by William Osler. Before going to the discussion proper, we will have to look at few definitions. First being monoarthritis, wherein only single joint is involved, and we call it as oligoarthritis if there are involvement of 2 to 4 joints, and if more than 4 joints are involved, we call it as polyarthritis. And we all know the definition of fever. So coming to the first case, this patient is a 22-year-old female who is a staff nurse by occupation. She came with an 8 days history of fever with erythematous macular rashes in her lower extremities. And it was associated with 7 days history of severe joint pains involving both the small and large joints associated with swelling and morning stiffness for 1 hour. So this is a case of acute polyarthritis. So before we go for the differentials, we have a polling. So I'll ask, request everybody to take up this poll. So kindly answer for this question. All are features of inflammatory arthritis except raised ESR-CRP. It affected joints are swollen. Pain worsens the physical activity, and morning stiffness lasts more than 1 hour. Okay, most of them have answered. So I'll end the poll. Right. So majority have answered it correct. Around 23% of the participants have got it wrong as option D. The answer is pain worsens the pain worsens with physical activity. That is the right answer. So if we look at the difference between with the inflammatory and non-inflammatory arthritis, basically the swelling is more common in inflammatory arthritis and it is usually absent in non-inflammatory or mechanical arthritis. However, bony swelling can be present. And classically, morning stiffness lasts more than 1 hour. However, it is of a short duration, usually lasting less than 30 minutes in non-inflammatory arthritis. And this point is very important. The activity actually improves the inflammatory type of pain and arthritis. However, in non-inflammatory mechanical causes, it worsens the symptoms. And there can be associated constitutional features like low-grade fever, weight loss, and fatigue. And there will be local rise of temperature, so we can have warm, and there can be reduced range of movement and pain due to the swelling in inflammatory arthritis. And inflammatory arthritis can have elevated ESR and CRP. So the important points to differentiate inflammatory and non-inflammatory are the duration of morning stiffness, that is lasting more than 1 hour. However, if the patient has already taken treatment, you might not have that classical history of morning stiffness because most of the patients might have received steroids previously. So you might not get that morning stiffness history. And a visible swelling again suggests inflammatory arthritis, and activity improving your symptoms is a very important feature which differentiates inflammatory from non-inflammatory arthritis. This patient had swelling, this patient had morning stiffness and joint swelling. So this was an inflammatory type of acute polyarthritis. So what can be the possible differentials? List is very huge. However, the possible things with the short duration of acute polyarthritis could be viral arthritis, which could be secondary to various infections like chikungunya, dengue, hepatitis B and C, HIV, parvo, and other viral infections. Or it could be a reactive arthritis, or it could be secondary to bacterial infections like gonococcus, brucellosis, meningococcus, or Lyme's disease, or it could be a presentation of acute rheumatic fever, or rarely it can be a presentation of septic arthritis where multiple joints are infected, or it could be a presentation of polyarticular gout or rarely leukemias. And other possible causes are the first presentation of various chronic arthritis. So it could be the earliest presentation of various diseases which leads to chronic polyarthritis. So this coming to this question. So we always get this confusion. So I request all everyone to take up this poll. So I request everybody to take up the poll. So fever precedes arthritis in all except viral arthritis, septic arthritis, Lyme's arthritis, and reactive arthritis. Whether it was hen or the egg. Okay, most of them have answered. I'm sorry to say that most of you have got this answer wrong. So 60% of the respondents have got it as reactive arthritis. However, the correct answer is septic arthritis. So, in case of viral arthritis, reactive arthritis, or Lyme's disease, fever usually precedes the arthritis, and it is fever is comes together with arthritis in cases of rheumatic fever, SLE, adult-onset Still disease, septic arthritis, vasculitis, and leukemia. And whenever you have a patient with arthritis and high fever, we have to consider septic arthritis, AOST, leukemia, and polyarticular gout. So septic arthritis, you usually have fever concomitant with arthritis, unlike viral or reactive or Lyme's disease, where fever usually precedes arthritis. This our patient also had a rash together with fever and polyarthritis. So the differentials in this case could be various autoimmune diseases like SLE, dermatomyositis, vasculitis, or adult onset Still's disease. Infectious diseases like viral arthritis, serum sickness, or rheumatic fever can be differentials. Other possibilities could be autoinflammatory diseases or various rarely leukemia. So our patient had history of similar illness in various family members and in the neighborhood, and there was an history of travel to Kerala, which is and this patient had acute onset rash with fever with multiple cases in similar locality. So this was a case of Chikungunya arthritis, and on investigation, the IgM and IgG antibodies were positive. So how does various viral arthritis present? So if we come for coronavirus or influenza virus, usually we see arthralgias and myalgias, and rarely we will have prolonged arthritis. However, if we take up parvovirus infection, rubella or hepatitis B, it leads to self-limited arthritis. And various alpha virus infections like dengue and chikungunya, you can lead to prolonged arthritis. So how do we dissect the possible cause of viral arthritis? In chikungunya, you can have a history of travel to endemic areas, and there can be severe polyarthritis with tenosynovitis. And in rubella, they can be having erythematous maculopapular rash. And in parvovirus infection, we can have transient rash, which we call as slap cheek appearance. And in hepatitis B and C or HIV infection, we can have a history of high risk behavior. And hepatitis C can have purpura, usually affecting the lower limbs. And rheumatoid factor, which we attribute to causing rheumatoid arthritis, can be positive in various infections like hepatitis B, C, or HIV infections. And if we come to differentiate dengue infection from chikungunya, fever is common to both the diseases, and arthritis is more common in chikungunya, and rash is common to both. Compared to chikungunya, dengue will present with more myalgia, and hemorrhage and dengue shock syndrome is specific for dengue. Coming to the next question, so I request all of you to take up this poll. All are true about chikungunya arthritis except fever usually lasts for 1 week, IgM antibody persists for 1 to 3 months, arthritis is mostly self-limiting, viremia lasts more than 3 months. Okay, so most of you got it right. So yeah, so viremia usually lasts for a very short time, like 1 week. Yes, arthritis is more. Even though I said that chikungunya arthritis can have chronic arthritis. In majority of the cases, it might be self-limiting disease also. So this coming to the epidemiology. Timeline of chikungunya arthritis. Usually fever and myalgia last for up to 7 to 10 days in most of the patients. And polyarthalgia can last for weeks to months. And after an incubation period of 2 to 6 days, uh, the symptomatic phase lasts for up to 1 week, and the arthritis can last for weeks to months. So viremia lasts usually only for 1 week, and IgM is detectable 3 to 8 days after symptom onset and persists for 1 to 3 months, and IgG persists for years. So this was all about viral arthritis. Coming to our second case, this was a 20-year-old lady who presented with fever for 1 month, joint pains for 1 month, anemia for 15 days, and she was found to have ANA positivity. So, with this investigation, this patient was referred for a possible diagnosis of SLE. And this patient was febrile and she had multiple tender joints, but there was no visible swelling. And the patient also had hepatosplenomegaly and with small lymph nodes. And on investigations, she had pancytopenia. Her HB was low, TLC was low, and she also had severe thrombocytopenia. So, what are the possible differentials if the patient has fever, arthritis, and pancytopenia?
Hi. There was a network glitch, so we'll be starting shortly. Please wait.
Sorry for the technical delay. I hope I am audible.
Yes, sir, you are audible.
Okay, thank you. So we'll take up this poll. Okay, fever, arthritis with pancytopenia. What are the all are the differentials except most of you have mixed response. So the correct answer is viral arthritis, vasculitis actually. So you can have pancytopenia in SLE, you can have it in leukemia. Viral arthritis, though it is unusual, can have. However, in vasculitis, you usually get leukocytic thrombocytosis. The correct answer was vasculitis, which almost 30%, right? Viral arthritis, few voted for SLE. So it's the response. So the correct answer is vasculitis. So how do we differentiate? Usually is acute in on all the three diseases are acute in onset, and SLE can have episode permanent course. And coming to the pattern of joint involvement, it can be migratory or additive, and predominantly involves small joints in viral arthritis. And similarly, in a SLE, it is additive involving the small joints. In leukemia, it can be migratory or additive. Uh, Viral arthritis can be associated with travel or history of travel or sore throat, and lupus can have other manifestations like skin lesions, photosensitivity, and various manifestations. And leukemia, you can have history of constitutional symptoms and weight loss. And lymphadenopathy is common to all the diseases, though it is less likely in viral arthritis. Hepatosplenomegaly is also less likely in viral arthritis, but it can be seen in both SLE and leukemia. And features which are more pointing towards a diagnosis of leukemia includes sternal tenderness and elevated LDH and uric acid. And classically, you will have pain more out of proportion to the swelling. So our patient had widespread pain but didn't have swelling. And on investigation, the LDH was elevated and uric acid was increased. And in peripheral smear, we could get acute lymphoblast. So this was a case of ALL, and always we have to look for sternal tenderness, and all ANA positivity is not SLE. So if you look at the various case series, the most common feature, musculoskeletal feature is bone and joint pain and not joint arthritis. You won't get the swelling in leukemias, you get bony pains. So this was about acute polyarthritis, which presented with viral arthritis, and the second case was a leukemia. So coming to the third case, this patient was a 25-year-old male who presented with high-grade fever for 15 days and joint pain for 7 days. And it involved right elbow, bilateral knee, and bilateral ankles with no other localizing features. And on history, he was having a history of sexual exposure 25 days back and had an history of urethritis. So this patient had presented with fever, polyarthritis, and history of sexual exposure. So what could be the possible differential diagnosis? Reactive arthritis, gonococcal arthritis, viral arthritis, and septic arthritis. So the first three choices, and septic arthritis was the correct answer. So with these diagnosis, arthritis and viral arthritis, compared to gonococcal arthritis, which presents with symmetric polyarthritis, it presents with asymmetric oligoarthritis, and it usually involves large joints involving the lower limb. However, gonococcal arthritis and viral arthritis involves the small joints of upper limb. And in gonococcal arthritis, you can have a history of vesiculopustular lesion, skin lesions, and in viral arthritis, you can have maculopapular rashes. There can be history of diarrhea in cases of reactive arthritis, and history of genitourinary infection is common to reactive and gonococcal arthritis and rarely viral arthritis. And reactive arthritis classically can have relapsing or chronic course, and gonococcal arthritis will have chronic course only if untreated, and viral arthritis is usually self-limiting, and rarely it can have prolonged arthritis like in Chikungunya arthritis. And other associated features like enthesitis, which is inflammation at the site of tendon or ligament insertion, or dactylitis, which is diffuse swelling of fingers or toes due to tenosynovitis, or conjunctivitis points towards the reactive arthritis. Gonococcal arthritis classically presents with tenosynovitis, though the differential diagnosis for tenosynovitis are wide. And viral arthritis can have constitutional symptoms, and there is a prompt response to NSAIDs in cases of reactive and viral arthritis. However, gonococcal arthritis requires antibiotics. So our patient had involvement of right elbow, bilateral knee, and ankle. So this was a predominantly lower limb involvement, and large joints were involved, and there was history suggestive of enthesitis. The patient had tenderness in the right heel at the side, insertion site of tendo Achilles, and his investigation showed raised inflammatory markers, and there was a prompt resolution of symptoms with NSAIDs. This was a case of reactive arthritis. So coming to our fourth case, this patient presented with 20, she was a 20-year-old female with 1 year history of inflammatory arthritis with high-grade fever. She had acute onset joint pains involving both the small and large joints, which involved over a period of 7 days. They were very severe and interfered with daily activities. And she also had high grade fever up to 103 degree, and it was partially reduced with antibiotics. However, after 3 months following blood tests, she was treated as possible inflammatory rheumatoid arthritis from an outside practitioner, and she was prescribed various uh, medications including sulfasalazine and methotrexate. With this, she had some 70 to 80% of relief of joint pains. However, she continued to have episodes of fever and polyarthritis. So the differential diagnosis in this scenario is very huge. It could be various infections which we and various including malignancies and various systemic rheumatic diseases. So considering her age and the duration of illness, we had a differentials of possible SLE, adult onset still disease, or less likely a malignancy like lymphoma. The patient didn't have any features suggestive of any definitive connective tissue disease. And on examination, she had a very low BMI and she had mild tachycardia and bilateral wrist. PIPs and MCP joints were tender and both the wrists were swollen. And she had hepatosplenomegaly. Liver was 3 centimeters palpable below the right subcostal margin and splenic tip was palpable. Rest of the examination was normal. She had anemia and her inflammatory markers were elevated and extensive workup like for various rheumatic diseases. We got ANA, rheumatoid factor, anti-CCP. All those investigations were normal. Chest X-ray was normal and extensive workup for infective causes including culture, echo were all not contributory. And on it, we also got imaging where there was hepatosplenomegaly and nothing else. And her ferritin was very high. It was 7,500. So with this, we made a diagnosis of adult onset Still's disease. We have to remember that adult onset Still's disease is a diagnosis of exclusion. So we have to look for the common infective and other causes. Only if other diagnoses are ruled out, we can have a diagnosis of adult onset Still's disease. So what are the classical features with which the patients with AOSD present? Fever is almost universal. Almost 100% of patients present with fever and almost 70 to 80% patients can have rash, which is a classically erythematous rash, which doesn't last more than a few hours to a day. And the patient can have arthritis in almost 90% of cases. Other features which can suggest AOSD are hepatosplenomegaly, lymphadenopathy, polyserositis. So other features are less frequent. So common features are fever, rash, arthritis, and hepatosplenomegaly. So, and adult onset Still's disease can have various presentation. It can be present with a single episode like a monocyclic illness, or it can have polycyclic illness, or it can have a chronic continuous presentation, wherein arthritis is chronic and fever comes on and off. So, in children with patient with systemic onset JAA, up to 50% of patients can present chronic polyarthritis, uh, which is even refractory to various drugs, including anti-TNF treatment. So, this was a case about adult onset Still's disease, which is a diagnosis of exclusion. Coming to our next case, this is a 24-year-old female who presented with 10 days history of fever, ankle pain, and subcutaneous nodules in the leg for 1 day. And on examination, the patient had erythema nodosum and her bilateral ankles were swollen and tender, and the patient didn't have any lymphadenopathy or hepatosplenomegaly. And the chest X-ray showed bilateral hilar lymph nodes with right paratracheal lymph nodes. So this patient had hilar lymphadenopathy and swollen ankle with erythema nodosum. So this comes to a triad which is called as Löfgren syndrome, which is a classic feature of sarcoidosis. So which presents with hilar lymphadenopathy, acute polyarthritis, usually ankles, and erythema nodosum. So we made a diagnosis of sarcoidosis. However, if there are various differential diagnoses which can mimic with this Löfgren syndrome, it can be a presentation of rheumatoid arthritis, wherein we have a symmetric polyarthritis with a positive rheumatoid factor. Even acute rheumatic fever can present with migratory arthritis with elevated inflammatory markers, and oligo gout, which can present with oligoarthritis with hyperuricemia, and histoplasma and tuberculosis, which can have hilar lymphadenopathy, arthritis, and rarely rheumatoid factor positivity also. So, sarcoidosis presents with acute or chronic sarcoid arthritis. In acute sarcoid arthritis, the common joints involved are wrist and knee, and in chronic arthritis, knee is knee and wrist are involved, and metacarpophalangeal joints and proximal interphalangeal joints can also be involved. And peripheral lymphadenopathy is common in chronic arthritis, and uveitis is also common in chronic sarcoid arthritis. So coming to the next case, this is a 32-year-old female who presented with 5 months of inflammatory polyarthritis with low-grade fever for 5 months. The patient didn't have any other features suggestive of connective tissue diseases, and this case is a case of chronic arthritis. So what are the differentials which can come with a low-grade fever? It can be rheumatoid arthritis, it can be SLE, systemic vasculitis, anti-synthetase syndrome, or Sjogren syndrome. So how do we differentiate these various diseases? In rheumatoid arthritis, usually it is symmetric involvement of joints. Classically, small joints of upper limb are involved, and it is an erosive type of arthritis. We will have joint erosion, we can have deformities, and rheumatoid factor and can be positive, and periarticular osteopenia can be there, and there will be severe synovitis and other features like vasculitis and serositis. In SLE, it is typically a non-erosive arthritis with fever and polyarthritis. In Sjogren syndrome, you can have Sicca symptoms, that is dryness of eyes and mouth, and there can be a lower limb purpura and polyneuropathy. And in anti-synthetase syndrome, it is there is non-erosive arthritis with interstitial lung disease and Raynaud's phenomenon and mechanics hand. And in vasculitis, again we will have symmetric small joint arthritis with neuropathy, ANCA positivity. And this patient had involvement of small joints of upper limb, and also the knee was involved, and there was mild anemia. Both the RF and anti-CCP were positive, and ESR was mildly elevated. And X-ray showed periarticular osteopenia with soft tissue swelling. We made a diagnosis of seropositive rheumatoid arthritis. So how do we approach a case of polyarthritis? So if the duration, first we look at the duration. If it is more than 6 weeks, then you call it as chronic polyarthritis. If it is less, then it is acute arthritis, wherein differentials like reactive arthritis, viral arthritis, which we saw previously, and crystal arthritis can be considered. And in chronic arthritis, we have to look whether it is symmetric or asymmetric. If it is symmetric, we have to look for possible rheumatoid arthritis and test for rheumatoid factor and CCP. And with that, we can make a diagnosis of rheumatoid arthritis. If it is asymmetric, then you have other DDs like reactive arthritis, spondyloarthritis, pseudogout, and various other diseases. So coming to the next question, I request to take up this poll. Rheumatoid factor is not positive in which of these diseases? Septic arthritis, Sjogren's, tuberculosis, and infective endocarditis. Well, most of you have got it right. The answer is septic arthritis. So, rheumatoid factor can be positive in various diseases. Like rheumatoid arthritis, in up to 70 to 85% patients, we will have rheumatoid factor positivity. In Sjogren's also, we can have large number of patients will have rheumatoid factor positivity. Various infections like tuberculosis, infective endocarditis, syphilis can have rheumatoid factor positivity. And the list of diseases which can have rheumatoid factor is very high. So rheumatoid factor positivity doesn't mean rheumatoid arthritis. The differential diagnoses are quite wide. So if you have an erosive arthritis, symmetric involvement, chronic arthritis of small joints of upper limb, then you consider a diagnosis of possibility of rheumatoid arthritis. So all ANA is not SLE, all rheumatoid factor is not rheumatoid arthritis. Coming to our next case, so 65-year-old male who presents with episodes of fever, joint pain, and swelling for last 6 months. Each episodes last 7 to 10 days. It was not associated with any other localizing features, and it was associated with raised inflammatory markers. So this was a case of episodic arthritis. So what are the possible differential diagnoses in this case? All are causes of episodic arthritis except crystal arthritis, Whipple's, autoinflammatory disease, and osteoarthritis. Most of you have got it right. The answer is osteoarthritis. So what are the differentials for episodic polyarthritis? It can be crystal-induced arthritis, it can be enteropathic arthritis, adult-onset Still disease, like we said, discussed previously, Lyme's disease, Hodgkin's disease, and rheumatic fever can all present with episodic polyarthritis. Other categories, autoinflammatory disease, which where there is a defect in innate immune pathway, we'll take up it at some other time. So how do we differentiate where all these diseases with episodic arthritis? In crystal-induced arthritis, you will have high uric acid, you can have, and synovial fluid analysis will usually give the possible diagnosis of crystal-induced arthritis. And the patient is usually an elderly male, and it usually presents with monoarthritis rather than polyarthritis. Only in the later case patients, later long-standing disease, you can have polyarthritis. Classically, it includes metatarsophalangeal joint. That is the first MTP in the lower limb is classically involved in gout, which is a crystal-induced arthritis. Other differentials could be enteropathic in arthritis secondary to IBD, wherein you have enthesitis, dactylitis, uveitis, or inflammatory back pain. Other differentials like which we took was adult-onset Still disease, Lyme's disease, where you have this erythema migrans uh, skin lesions, and Hodgkin's disease, where you have painless rubbery lymph nodes. And other, you usually have a fulminant polyarthritis with weight loss, bony pain, and bleeding manifestation. So next question, true about acute rheumatic fever. Carditis is uncommon in children. Rheumatoid nodules are common in adults. Erythema marginatum is usually seen in adults. Arthritis is migratory in children. So this is a mixed response. The correct answer is the option 4. Arthritis is migratory in children. So what are the difference between children in adult rheumatic fever. Most of the manifestations are common in children: carditis, rheumatoid nodules, erythema marginatum, and it is uncommon in adults. And arthritis is classically migratory in children, and it is additive in adults. A for A. So, how do we define chronic arthritis? Okay, most of you have answered correct. It is more than 6 weeks. However, few have answered it as more than 3 months. No, chronic arthritis lasts, any arthritis which lasts more than 6 weeks is considered as chronic arthritis. So, distal interphalangeal joint is usually spared in which arthritis? Distal interphalangeal joint is usually spared in which arthritis? Okay, this is a mixed response. So the correct answer is rheumatoid arthritis. However, many have opted it for osteoarthritis as well. So what are the common joints involved in each of the arthritis? In rheumatoid arthritis, they're classically a DAP is spared and thoracolumbar spine is spared. In at least as low as 5% patients, you can have DIP involvement. Otherwise, classically, patient says that there is involvement of MCP and PIP joints and the rest, but not the DIP in rheumatoid arthritis. In osteoarthritis, it's the converse, like MCP is spared and PIP and DIP are involved. In reactive arthritis and psoriatic or enteropathic arthritis, it's usually lower limb predominant and oligoarthritis. In psoriatic arthritis, you can have involvement of PIP, DIP joints. And in polyartical gout, classically you have involvement of first MTP and there is pairing of axial uh, joints in polyarticular gout and crystal arthritis. Uh, and in sarcoid, commonly ankle and knee is involved. And hemochromatosis, classically MCP, that is second and third MCP joint involvement is classically seen in hemochromatosis. So, summarizing, how do we approach case with polyarthritis? First, we have to see whether it is articular or periarticular, then whether it is acute or chronic, whether it is inflammatory or non-inflammatory, and how many joints, whether it is monoarthritis, polyarthritis, or oligoarthritis. And if it is an articular, if it is acute monoarticular, then the differentials could be gout, septic arthritis, fracture, carpal tunnel syndrome. And if it is articular and if it is a non-articular condition, then trauma, bursitis, tendinitis, myositis, fibromyalgia should be considered. And if it is inflammatory arthritis, whether it is acute or chronic. If it is acute, then it could be a septic arthritis, gout, reactive arthritis, or an initial presentation of chronic arthritis. And in chronic arthritis, it could be chronic non-inflammatory arthritis like Charcot's arthritis, hemochromatosis, or osteonecrosis, or osteoarthritis. Osteoarthritis, classically involvement of DIP and first carpometacarpal joint, hip and knee joint involvement will be common in osteoarthritis. And chronic inflammatory arthritis, depending on the number of joints involved, if it is very few, then it could be psoriatic or reactive arthritis. And if it is polyarthritis, if there is involvement of PAP, MCP, then it is rheumatoid arthritis. And if it is non-erosive, other disease could be SLE, polymyositis, or scleroderma. So this is how we approach case of polyarthritis. So coming to the next question, erosive disease is common in which of the following diseases? Sjogren syndrome, SLE, antisynthetase syndrome, and rheumatoid arthritis. So I think my purpose is served. So majority have got it right. So it is rheumatoid arthritis. Erosive arthritis is classical feature of rheumatoid arthritis. Though diseases like adult-onset Still disease can also have erosive arthritis. It is usually common in rheumatoid arthritis compared to the other three differential diagnoses. So this is the last poll. Arthritis associated with HIV. Presents with all except reactive arthritis, septic arthritis, symmetric polyarthritis, or episodic arthritis. So this is a little mixed response. So the answer is septic arthritis. So HIV-associated arthritis can have very wide presentation. It can present with an lower limb predominant oligoarthritis, or it can present with symmetric persistent polyarthritis, or it can present like reactive or psoriatic arthritis, and rarely it can present as septic arthritis, which is secondary to opportunistic infections, not HIV per se. So summarizing, the differentials diagnosis of fever and polyarthritis is wide. Accurate history, thorough examination, and appropriate lab and imaging studies can help in the diagnosis. The cause of arthritis may be revealed by the associated symptoms and signs in other organ systems, and early preemptive diagnosis and appropriate management will contribute to the better outcomes. So these are our various Twitter IDs. If there are any questions, you can post here.
Okay, that was quite an enriching talk. So, are there any queries? I don't see anything in the chat box, or actually we re-logged in, so we might have missed a few questions. So, if anyone wants to ask any questions, can retype or resend it on the chat, or can unmute themselves and ask the questions. Okay. So I think it was a great learning at me as well, because definitely when it depends on your specialist. So if a patient comes to me with fever and pain and swelling, I will think of infective causes. He would definitely think about any non-infective causes. But as you can see, most of these are non-infective. But not to forget, there can be infective causes should not be missed, because most of these non-infective causes usually have a long-term course. So these patients can wait, like the treatment can wait, but the infective causes. So we had recently a patient who had infective endocarditis presenting to us with polyarthritis. So because of the septic emboli. So these diagnoses cannot be missed, and if the infective diagnosis is missed, the patient can as well die. So with that, we end this session. I will be posting the feedback. Okay, management part we will be taking in further sessions. So that's what I wanted to announce. So next webinar I'll be having is controversies in ID. So previously I had this debate series, controversies in ID, which was a great success. So we are returning with the second season, that is